We've already heard so far the importance of asking some of the more naive questions. And that is, in a sense, what I'm here to do, to open up some of the debate. And what I'm going to do is to have a conversation with Margot and MariaLuisa, and then going to throw the floor open, and Joe and Zaid will be coming around with microphones and so on as needed, and keeping the conversation flowing. But in terms of the sorts of questions we're going to address, we're going to be talking about what are human rights and what are health systems. Once upon a time, I didn't think those questions in a way needed to be asked. I remember having a discussion with a lawyer friend once and naively thinking I knew what human rights were all about. He was in lawyer mode and having great fun, and of course took me apart as I revealed my ignorance of what this involved. Likewise, in discussing health systems, our very first session was on reforming healthcare systems, getting to know, indeed, some of the complexity involved in that discussion was very illuminating. So we're going to start with the very basic question, which I'm going to put to Margot. What are human rights in this context?
Yeah, I would like to answer that question by citing a landless laborer that I spoke to some time back in India. She worked as a landless laborer on very fertile land. She grew rice, but she was starving, so she didn't have access to the food that she grew. And she said, I find it very unfair that some people have so much food and we have so little. It should have been equal. But if I ask a question to the landlord, he would punish me. There is nothing in the world that I fear more than the rich. I'm afraid of their harassment, afraid of their violence, and I'm afraid of losing my job. So this is kind of a complex issue that you have been discussing this morning. There is plenty of food, but she has no access to the food. And I would say the human rights-based approach gives us a clear focus on the individuals. So we should remember that we are talking about people and not about the food or the medicines or the hospitals. You know, they are means to reach some goal. And another point I would like to make, you know, that it makes human rights a unique tool, is that they make us look behind. Why is it like that? And also here I would like to give you an example. I spoke to representatives of UNICEF in the headquarters, and they told me, previously, before we had the rights-based approach, we used to think that if we got 8 children in school, we were very satisfied. That was great. But now with the human rights approach, we look at the 2 who are left out of school and try to find out why they are not included. We try to find out how can we also make them a part. And that means that they have to look at power structures, like Leonardo discussed yesterday. They have to look at complex issues. And then I would like to mention the third dimension. The rights-based approach makes us look at the role of the government. What's the role of the government? So I'll just have a little water. For example, with the UNICEF case, is the government, the local government, is it actively working against getting the 2 children into school, like you see, for example, in Darfur in Sudan? Or are they passively watching third parties, you know, making the girls, for example, not being able to go to school, like Taliban in Afghanistan? Or is it because they don't have enough resources, like you can see in Somaliland, Ethiopia, other places? So I think, you know, this is the core of a human rights-based approach. So it's the opposite of privileges. It's the opposite also of charity. You are entitled to these rights. And I think the test case, if you're a successful government, is if you manage to include minority groups, if you manage to include the marginalized people. Yeah.
Thank you very much. And one of the points you started with, I think, is so important, is how we can deal with complex problems and problems on a population base and keep a focus on the individual at the same time. That's difficult and very thought-provoking. In the history of the development of the idea of human rights, the French Revolution famously was foundational. But it went wrong in a number of ways, and one of the ways was that it never resolved the question of whether you were looking at rights on a population level as against an individual level. And there's a tension there, which we might perhaps come back to, and I think that's implicit in some of what you were saying. Could you tell us a little bit more about something that was mentioned yesterday? Leo came up with what I thought was a rather wonderful acronym, which was PANTHER. And this was about things like participation and accountability. Could you explain that a little bit more?
Yes. That's something I really, a concept I really appreciate. PANTHER is an abbreviation for 7 core elements of human rights, which you can apply for all kinds of human rights, such as the right to health, right to food, other human rights. So P is for participation. You should ask children to come to the parliament, to come to the ministry, to come to the judge, and ask them, what's your opinion? What do you think is important for us to be able to reach our goals, and what are your goals? And then A, accountability. You should be predictable, you should do what you say, and you should act responsibly. And non-discrimination. That's a key, of course, for a human rights approach. So you should focus on the most marginalized, the most vulnerable. You should try to lift them up and include them. I really like John Rawls' concept, of thinking of yourself as responsible for developing politics, and then you should think of yourself as being reborn, and you don't know where in society you will end up. So when you develop policies, you should think, as if you could end up being you, or somebody living on the street, or, that's something that helps us think, inclusive. And then you have the transparency, which has been mentioned several times. I think that's very important. To make sure you reach the population, you need to publish the budget. You need to just put it on the wall. Make everybody see what you spend your money on. You will see people who are a part of the system, they will spend the money more wisely. And people who see, they will enhance their consciousness about what they have access to. And then you have the H, human dignity. Saeed, you mentioned yesterday UNICEF in India. I'd like just to tell you the follow-up of that. UNICEF, they were not very happy about the way they had proceeded in India with the vaccination, with the first vaccination, and they were throwing stones, as Saeed said. But actually they decided we don't want to do it this way. So they sat down and tried to find a solution, and they ended up having long discussions for weeks with the population, with the people who are throwing stones. They try, through local NGOs, they got access to them, and it turned out that this was primarily tribal people. They were sure these health officials came to sterilize them by force. So they thought that was what was going to happen, because that had happened previously. And then when they learned and felt, they got respect from the staff, they felt dignified, they also started accepting. So they willingly accepted to be get vaccinations for the children. And then you have the E, empowerment. I mentioned this landless laborer, Gita. She didn't have the empowerment needed to stand up for herself. In her village, many people were treated the same way, but there were two young men that they spoke to, and they had been going to school, and they knew of their rights, and they were not afraid of speaking up. And also the landlord was not, he didn't dare to punish them in any way, as they would do with the others. So they had got the empowerment. And then the last one is rule of law. It's tightly connected to the accountability. You should make sure, there are places where you can go and complain. It could be like a legal system, paralegal system, it could be an ombuds office, human rights, a place where you can go and report and discuss and get advice.
Thank you. Now, I referred earlier to the lawyer friend who cheerfully filleted everything I was saying about human rights. And one of his points was, of course, that if you have a set of rights, there must be a matching set of responsibilities, of obligations. And one of the problems in the discussion of human rights is that that's not always made fully clear as to where responsibilities and obligations lie. So could you tell us a little bit more about how that works, that side of it?
Oh yeah, that's something we could discuss for days, I think. And we actually discussed it this morning at my table. Who have the obligations? Is it the government? Is it the business? Is it like every individual? And there are different answers. But if you look at the history of the human rights, at least from the UN history, the governments were the ones who made the decisions, and they have signed and ratified the conventions. 150 countries have ratified the Convention on Economic, Social, and Cultural Rights. So they have the legal obligations and also political and moral obligations. But you could, of course, say that we as citizens have moral obligations. And with this society where business also have huge implications on society, we should look at their roles as well. But I would stress that the governments are the ones legally obliged to respect, protect, and fulfill the rights.
Okay, thank you. Now, if we're thinking about a human rights-based health system, and we'll be coming on to elaborating this with MariaLuisa shortly, could you describe some of the key characteristics? How could we recognize a health system that was truly human rights-based?
Yeah, that's not very easy. I think there are many different answers to that, but there is a common understanding of the 3 A's and the Q that was mentioned yesterday as key for health systems. And those are availability, accessibility, acceptability, and quality. Do you want me to elaborate a little bit?
A little bit on that.
Yes. Okay, the availability. The government should make sure medicines are produced, goods are there, health, the services, and facilities. They should be available in the society. And we have an example from Argentina. I don't know if you would like to just help me with that, with a hemorrhagic fever, MariaLuisa.
Sure. Well, this example for availability, for making available a vaccine in Argentina, what happened was that when the PAHO, the WHO branch for Latin America, stopped the funding of the production, the national production of these vaccines, then there was, it needed to be available, and then there was a lot of claims for the state, a judicial claim, for fulfilling this obligation of the state to produce again this vaccine, to make it available.
Yes.
And that's what happened. So then the country went back to the production of the vaccine.
Yeah, so that's a very good example. And then you have the accessibility. So the goods and health facilities and services, they should reach out to the population. You shouldn't need to walk for 4 days to come to the healthcare. And it should also be affordable. It shouldn't cost you 2 years of salaries to get plaster for your broken arm. And it should be accessible without discrimination. And also health information should be provided. I would like to give you another example from India. A woman named Lakshmi, she was a Dalit woman, that means she was from the scheduled caste. She was pregnant, she went to the hospital when she was in labor, and she was rejected because she couldn't find her ration card. And then she went back home, and then the day after she went back. She was in labor for 3 days, she came back to the hospital for 3 days, the third day she died. And the court decided that people should not hereafter be denied access to hospitals. So that's an example of, it's there, the services are there, but it's not accessible. And then acceptability. The goods and facilities and services, they should be respectful of medical ethics, and they should be culturally appropriate. And of course, informed consent is very important. And here I have an example from Hungary, very close to here, where we are now. A woman from the Roma community, her name was Andrea. She was also pregnant. The Roma community is highly discriminated in Europe. And she went to the hospital, and the doctor decided she needed a cesarean section, and she needed to sign the form of consent. But the doctor had, by hand, scribbled down in his language, which she didn't understand. He had scribbled that, I agree to be sterilized. So she woke up after the cesarean, and her baby had died, and she was sterilized. So she took it to the UN Committee on Elimination Against Discrimination Against Women, and they decided it was a violation of the right to health, and she was given compensation. Yeah. That's an example of acceptability. And then you have the good quality. The health facilities, the goods, services, they should be scientifically and medically appropriate, and they should have good quality. You should be safe. Here is an example from Bangladesh, where skimmed milk was imported. And it turned out that it was contaminated by radioactive material. And the government was then requested to test and make sure that from now on the skimmed milk would be safe to drink. So that's an example of that. But these are some court cases that have been important for the right to health. But Siri, I think tomorrow she will also explain how they can be harmful to the right to health, because they focus on the individuals, whereas the health system should have a broader focus. So there are always dilemmas here.
Thank you very much. And as you began your answer on that, you pointed out how complex and how many issues there are to encompass under these sorts of principles. Those are some very, very clear initial leads, and I think this is something that may well crop up in discussion in a few minutes again, but also as we think, if we do decide to put a Salzburg statement together, those principles will be an interesting starting point to start thinking through, debating to, adding to, and so forth. So thank you. Thank you very much. Now finally, to sum up this part, so much has been implicit, obviously, in what you've already said, but could you give us maybe some more of the reasons why you think we should base our health systems on a human rights approach?
Yeah. Now I can speak. I work in a donor agency in NORAD, the Norwegian Agency for Development Cooperation, and we want to see that the money we spend on development aid, has good results. And what I see in my work is that if we manage to have a rights-based approach to whatever program, we get better results, and we also get more sustainable results. So it's a very effective way of spending money, because you remember, you have the pantry, so if you're sure that all those are fulfilled, you're pretty sure that the program you develop is a good one. Either if it's on high level or just tiny, small scale. So, for example, instead of NGOs developing parallel clinics, they will collaborate with the government and they will make sure it's a sustainable public healthcare system. So the human rights approach give us good tools. We see, in Norway, we see that women's rights, the implementation of women's rights has actually economically been of greater importance than the oil and gas revenues combined. And that's a lot, because we are one of the biggest exporters of oil and gas. So it's in everybody's interest. The Ministry of Finance was actually leading the process of, making sure that the women's rights were enforced, because we couldn't afford not including them in the society. And we see the same for the rights of persons with disabilities. International Labour Organization has tried to measure. It's hard to measure because the statistics on disabilities are very poor, but they have done modest calculations and found that if we manage to include people with disabilities in the society and enhance their rights, we will increase our global gross GDP by 4 to 7%. So up to 7%. That's amazing. So we see that the World Bank has done good research on the economic growth if we manage to focus on women's rights, for example. So there are many very good economic reasons, but I would say also, last but not least, we also get a more human society.
That's very, very compelling arguments. Can I be a little bit provocative here, though, and ask, is there a downside? Is there a way in which the human rights-based approach could be more problematic than simply win-win?
Yes, I think it's complex, it's demanding, it takes time to understand what it requires from you. And it's not a quick fix. You need to be patient. So, but I do believe, if we manage, perhaps I'm a bit naive. I'm sure I will get examples from you guys later on that there can be side effects that I'm not aware of, but so far, when I go through research done on it and visit programs in villages, I'm quite impressed, by the results.
I think for me, and this relates both to what Joe was saying and Zaid as we started this morning, and my own experience talking about human rights with my lawyer friend, is that it's a complex problem. And it's so often in public debate regarded in a sense as a simple problem, a headline problem, as it were. And this is what we're here to do, of course, is to work through the complexity of it as well. One other thought, as you were talking, is that we're talking about a relationship between human rights and health systems. And of course, it's a two-way thing. To a certain extent, we're tilted in one direction at this session. We're looking at the way that human rights informs health and health systems. Well, there is a reverse dynamic as well. And while you were talking, I was reminded of a colleague who was working on gender issues in India. And she was describing how in a health project, they were helping villagers to set up clinics and giving some training to some of the villagers to do some of the very basic primary care. Now, those villagers who were delivering the primary care were women. And what happened was that they started to collaborate together and they started to provide a service of a particular and vital sort to the village as a whole. And what was observed was a shift in gender relations in that village. And what you had was a wonderful sort of virtuous cycle, as it were, because not only were you addressing health problems, you were also addressing questions around gender and human rights in that context as well. So there is a cumulative effect here, which I think is broader than simply the health and healthcare agenda. But back to health and health systems in particular. Now we're going to turn for a few minutes to MariaLuisa and then bring the two halves together in general discussion. But first of all, MariaLuisa, could you take us back to base point, as it were, and tell us a little bit more about what are health systems. What are the essential characteristics we must bear in mind? What makes a system?
Well, first, I'm sorry to disappoint you because you are asking me something that really stays in the little black spot there that they just draw. So, and this is giving job and times for many, many, many people to try to describe what a health system is. And I tell you that it really, what economists say all the time, and I'm an economist and I will hate to say that, but it depends. It depends who you ask and what for. So there have been descriptions of what a health system is if you want to just describe. So in the 80s and 90s, there was a lot of literature on like health systems refers to the number of physicians, nurses, beds, hospital beds, medical inputs, etc., that you can use. Then it went more into, well, there's not just for a description, like a snapshot from an airplane. So you see what is the health system, and others call it the health sector. So it's not a dynamic vision of what it is, but just the parts, the sum of its parts. Then it went more like, well, but maybe it's more important to think of health systems in terms of relationships across different actors or pieces of a health system that are associated with a goal, with a specific goal, similarly to what Margot was referring to the AAAQ. So a health system will be a set of actors, meaning government, physicians, clinics, industry, patients, that relate to each other with the goal, with specific goals, to reach, we could say it in the terms of AAQ, or we can say it in the way of, well, to reach a high level and distribution of health outcomes, of satisfaction, patient satisfaction, and also to protect from the financial ruin when people get sick. So not let people go into poverty because they get sick. And that to make it the highest possible level and for in an equitable way, the best distribution they can get. So.
Right, so those are some of the goals and why we have a health system. Yeah.
Yes. So, but the important thing, I think, is to understand that a system is it's a dynamic body that moves and changes all the time, and that it relates to specific goals. That is the very important thing. And what happens in between is the modulation of all these relationships. For example, the population would like the government to be able to arrange all these relationships to provide the best of what they need. But then the government will come with, let's say, a benefit plan or a basket of services to try to modulate that action. Okay, what are we going to provide, where, and for whom? And therefore, they also do many other things, targeting mechanisms. How do we find the poor in terms of inclusion, as Margot was saying? So how do we identify them? How do we provide the services for them? How do we mobilize resources to be able to pay for all that? So that's very much like what we have to always keep in mind. I try to construct a definition of a health system comparing with a human body in a way. Why I was doing that? Because I was giving a class at the bank, actually, on what are health systems and so on. And there were, almost everybody in the audience were medical doctors. So I noticed they were looking at me like, okay, what is she talking about? So then the best thought that came to my mind was to explain, well, look, a health system is like a body. You can describe, you have a liver, you have a brain, you have hands, you have feet, and that's it. But that doesn't give you an understanding of what do you do with a patient when the patient comes to the emergency room with a fever. So you have choices. You said, oh, has a fever, let's give an aspirin and get well. But you actually are not looking for the causes of the fever. So what is exactly what this person has? The same happens with the system. The same thing. If you understand a health system as this set of complex relationships between all these different actors or members, and there's even more. There are others that will include the outside of the system, everything else that determines health, education, environment, water, etc. But if the purpose is to understand the system in relationship of what you can do to improve it, then you have to define that universe and say what is under, let's say if it's a Ministry of Health, under our domain to influence how this works. So the same that the doctor with a patient, what is under my domain to make this person function better? And they are also give other advice, eat better, run every morning, which I don't do, all these kind of things. But they can also say, let me give you this medication, or would you agree to have this type of service to get better? So I hate to say this word, I have to say it. It's a very complex concept, but what is important is to understand that it's a dynamic body and that there are instruments that could modulate the relationship between the different actors in the system.
Okay, you referred to government and so on, and you mentioned stakeholders. Could you elaborate a bit more on stakeholders and their role? In a sense, this is almost asking you to dissect the body, as it were, because obviously the stakeholders are in dynamic relationship with one another, and we must never forget that. But could you talk a little bit more about how we define the stakeholders?
Okay, so the stakeholders, we can start with the patients or the population. Let's call it population, the citizens. So those are a big body of stakeholders, which are all of us, in a way, that if you think through the concepts that Margot was saying, we want them to participate, to be empowered, to have voice, to be able to identify or reveal their preferences. Then you have the government, which could be a central government or a local authority that have a specific responsibility, as you were talking about, to provide or to look at what is available or in this setting, in this society, country, municipality, whatever, and organize it in the best way to meet the needs of that population. Then you could have the providers that we all know, and so, the medical doctors, the nurses, the pharmacists, the midwives, everybody that will provide some service for citizens in terms to improve their health. To have insurers in some settings, not in others. You can have a public or private providers and public or private insurers. Who am I forgetting? You have the industries that produce the medical inputs, the medicines that are necessary, for all the inputs that are necessary to provide a service. So those like a minimized description of what different stakeholders could be.
I think one of the things that's very interesting is we just think through that list, and perhaps this is to bear in mind for future discussion, is that those stakeholders are very different organs, as it were. They're organized in very different ways. They express themselves in very different ways, and they have all sorts of trade-offs they're engaged in outside the health system. As you said, there are things outside the body that are making the difference. And above all else, there's very different power relationships, both structurally between those different stakeholders. But of course, that also varies from setting to setting. And I think that's a theme that we will inevitably be coming back to as we see how the body works as a whole. But for now, can I just finish in a sense as with one of the questions that asked Margot? Could you give us your vision of what a rights-based health system would look like?
Very well. I think that Margot gave me the right letters and words to look into this. And I would imagine that a system that is designed with a rights-based approach will be one that allows for participation. So, for example, I remember in the 90s in Oregon, in the US, they did all this big movement for society to participate in revealing, their needs and preferences for constructing a benefits basket. Very different from other places that will be 3 people sitting in a room, closed doors, and do some technical analysis and write a list of things. So it should be one that could be participatory and at the same time empower citizens to participate on the decisions of what is going to be done, how is it going to be organized, who is involved, how they manage the power relationships that you were describing. It should be one that is transparent. So many systems in the world are now struggling, and more than struggling, let's say, trying to improve their transparency, not only in their decisions, but on the information. So to put outside the information so the citizens can say, okay, I prefer to go to this clinic or this other because this one has not very good ratings in terms of quality, or totally transparent into what they can offer and they cannot offer. So it's improving more and more, and as you see, even I think the US is a little bit of an extreme of many things, but even when you get a prescription medication, you get a big paper that explains a lot of information about the medication you're going to have and what could happen and not happen, and etc. So the health system should be one that allows for, I'm trying to remember your panther, so transparency, empowerment, accountability, very difficult and very important. And a health system that is designed and operationalized on a rights-based approach should be one that has instruments for citizens to be able to make states accountable for what they offer. But not only the state. So all the actors should be accountable for what they are supposed to contribute to that dynamic of a health system. And there should be instruments where you can claim that accountability, let's say. So there should be that transparency of responsibilities, and at the same time there should be instruments where citizens could ask the others for what they should be accountable. For example, the physicians are accountable for providing services that are of good quality and that are appropriate and that they are delivered with human dignity. Then the system has to think about what instruments are they going to put in place to make that happen, and that the other party could claim for that. So, okay, how do I know that you are giving me something that is of quality? So it is, I think it is a system that has to think about a lot of different instruments that modulate this relationship between not only patients and providers, but institutions, government and citizens, and so on.
Thank you very much, and thank you both for that illuminating mapping out of where we stand with health rights and health systems. And just to open up more general debate, I'd like to ask for, first of all, both your comments on a particular example and then opening to the floor. This will be an example well known to some of you, not necessarily all. Just over a decade ago in the UK, an article was published suggesting that there was a link between a vaccine given to children called MMR, this is measles, mumps, and rubella, combined vaccine, and there was a suggestion there was a link between that and autism. Now, the press in the UK leapt upon this, and it became a huge issue, and a sort of panic gripped the country. And what started to happen was that despite a lot of, as it were, received opinion despite the government's chief medical officers and scientists saying, no, it is much better that children should have this vaccine, that the case about the link with autism is not proved. Despite that, many parents did not have their children vaccinated. Incidentally, it has since been proved conclusively that this article was bad science. But it was out there in public debate. And in public debate, of course, particularly when mediated by the press, people are not necessarily looking, as it were, at the footnotes and working through the science. Now, for me, this sets up a rather tragic and very interesting problem, because there you have parents exercising their right to determine what happened to their child. But there are complexities here. First of all, was it the same that the right of the parent, being driven by a very understandable anxiety, is actually identical with the right of the child to the best possible health care? Because what physicians knew was that although there was an alternative, you could have the vaccine in single doses, because of people's busy lives, this is just a sort of sociological fact, the vaccinations would not occur if they weren't given in the combined dose. So there were strong implications for the health of individual children. And of course, we should all remember that measles is a killer. Second point, and that is there is the question of herd immunity. There is the problem that the exercise of the right not to have that vaccine, when aggregated, had an impact on the whole community, so that you could start to get childhood diseases that were pretty much completely under control, starting to spread through the population again and impacting on many other children. So it seems to me that this is one of those areas, it's one of those instances where it absolutely talks to a human rights agenda, but introduces some of the complexities in that debate. So perhaps I could ask Margot, first of all, for some of your comments on that case, then MariaLuisa, and then we'll open to floor discussion.
Oh, well, this is very difficult. I'm not sure if I have a good answer, but I'd just like to mention that yes, individuals, we have rights, but we do also have duties. And of course, here it's the society as a whole versus the individual's rights. We have different dilemmas as well when it comes to freedom of religion and, for example, female genital mutilation. You know, the rights of the parents are sometimes very different from the rights of the children and from the community as a whole. But I would like actually to pose the question further on to you and also to the rest of the group, if I may.
Very well. Well, I think that if one thinks of that from the system's perspective, that example that you were putting, one will have to think of two things that are very controversial. One, you know, should I protect the individual or should I protect the community, the population as a whole? So the system, from the system perspective and the policymaker perspective, maybe what is important in this case is to think that the externalities that it provides, the issue of not vaccinating a child, so giving the opportunity for parents to say no, means probably creating an issue, a problem for the community as a whole for quite some time, which means for the system that they have to make provisions for dealing with that in a different way. So it is quite complex because they will have to think of, okay, we have to allocate resources in a different way if all of a sudden there is an epidemic, for example. So we also have to think of, okay, how are we going to mobilize all the physical inputs to deal with the future children that may get sick and may die, as you say. How are we going to deal with the providers? What do we tell the physicians? Are you obliged then now to discuss and convince with the parents that they really have to vaccinate these children? And how do we incentive them to do that? Do we pay them differently? Do we give them a bonus if they talk with the parents about this issue? Because we have to primarily protect the population's health. So it is attain the highest level of health in a nation. So that becomes an issue that will end up permeating all the different policy options that a policymaker could have. Regulation, for example. Do we put a regulation that says from now on nobody can say no to this? Or do we actually don't put a regulation, we just pay differently the providers so they will really go after. They go out of the clinic and go to the houses and bring the kids and vaccinate them, for example. Or do we just simply mobilize more funding and resources and make sure that there are more of these vaccines available everywhere? So it creates a whole different dynamic, and then we start moving into the different circle there that they were drawing.
Right, thank you very much. Just a last couple of thoughts on that, and then Ziad and Joe will be coming around with the mic, and as soon as you get the mic, then that will be an opportunity to speak. But a couple of last reflections on MMR. I remember at the time talking to a colleague, extremely well informed in the sense that he was then and still does write articles on health and healthcare or do research projects, Economist Intelligence Unit. It's an area of professional interest, and his child was of an age to be vaccinated. And I asked him whether he was going to, and his wife were going to do so, and he just paused forever and just said, if this is true, and he says, I'm pretty sure it isn't, of course, but if it were, and my child became autistic, it would be my fault. And that terrific sense of weight, of responsibility in that, which had a sort of potentially perverse outcome, but so deeply felt. And we'll be coming back later in our discussions to some of the extraordinary imbalances in health and healthcare in terms of who has the expertise, who has the decision-making power. And very, very tricky. And this suddenly, in a way that parents were utterly unprepared for, it threw the decision-making power at them, and they couldn't deal with it. And this is why, as you were saying and we were hearing earlier, participation is so important, so that it's not just that sort of terribly raw reaction that you need. And my last point is that something that gave me a lot of thought yesterday is a very important comment about, how do you treat people who are, as it were, putting their own health at risk because they're tobacco or obese or whatever. And of course, these are not free choices. That was a point that was made, that these are not simply the individual thinking yes or no to something. Equally, when we're discussing issues around rights, we very naturally focus on governments and other agencies with power, but there is also something to be explored here about that individual exercise of rights and the individual exercise of responsibilities. And I think this particular example plays to that as well, and I'm sure we'll come back to that.